Good evening to everyone. Allow me to introduce the moderators for the session, myself, Dr. Salima Kanji, and my co-moderator, Milan Ocheng, will be your moderators for this inaugural webinar from the Patient Safety Working Group of the Acquire African Community of Practice. So on behalf of the Patient Safety Working Group and the entire Acquire team, we're thrilled to welcome you to this quality of care services. Today's topic is the importance of patient involvement in the diagnostic process. Today marks a significant milestone in our journey, building the proposal of our community of practice during the Acquire Quality Improvement Leadership Workshop on building quality improvement into Africa's health system agenda. So as we start this journey, we are united by our shared commitment to improving patient safety, especially as we observe World Patient Safety Day this September. As you can see on the slide, the program is availed for the session. And we welcome you once again. This program is just beginning, the first of many, as we kickstart our activities and dive deep into enhancing patient safety and quality of care across Africa. I will go to the next agenda on the item. You will please check your chat box as a copy of the slides, and the program will be available here for you to follow. So do please check your chat box so that you can be aware of the program copy and the slides. And you can then follow us about our chat box. Please do write your name, your location, and your role in the chat box. Feel free to say hello to those who are sharing. As a healthcare professional involved in quality improvement, we'd love to hear from you. What strategies have you found effective in emphasizing the importance of patient involvement in the diagnostic journey? And please do share your insights in the chat box. So I'll give a minute for my co-moderator, Milan, to come on board as we then proceed with the webinar. Can I see Milan?
Thank you, Dr. Salima. As members continue to write their name and their role and the country that they are hearing us from, we would be able to request that we have some housekeeping rules that we be able to follow. Please keep your microphones always muted unless prompted otherwise. For questions and inquiries, kindly connect with us in the chat box. Please ensure a stable internet connection, uninterrupted experience. Respect the privacy and confidentiality of all the participants. We'd also wish to introduce Acquire. What does Acquire do to improve healthcare at the front line? We basically bridge the know-do gap by training frontline healthcare in quality improvement practice. And this is done through a solution to quality improvement. One, through building the capacity of frontline health workers in quality improvement, creating an enabling environment for evidence-based quality improvement practice within institutions that healthcare providers work in, and foster a community to drive uptake in quality improvement practice. So we wish to introduce our community of practice. First, we welcome you to our first webinar of Quality Improvement and Patient Experience Working Group. And basically, we are looking at the significant steps today. We embark on a significant journey together to be able to get to where we want to be in terms of quality improvement and patient experience, focusing on diagnostics and processes and how we involve patients towards patient safety. So basically, our inspiration is stemming from a choir leadership workshop that was titled Building Quality Improvement into Africa's Health System Agenda. Our objective is to kickstart our series of activities aimed at enhancing patient safety and quality of care that is crafted for Africa by African frontline healthcare workers. The purpose of this community of practice is basically to identify and address central challenges impacting patient safety and quality improvement. The challenges that have been seen is to explore specific obstacles that are faced by healthcare workers across various settings in Africa, and to be able to look at the possible solutions by discussing actionable strategies and solutions developed by Africans to overcome these challenges and improve the outcomes. Looking forward, this session is to be the first in a series that is designed to foster deep engagement and proactive problem solving within our community. Your participation and insights are crucial as we aim to transform healthcare practices across the continent with solutions crafted by African healthcare professionals for the unique context. So let us learn together. So you can put your question in the chat box. You can also make sure that you take away the biggest learning points. So let us learn together. Your moderators will be I, Milan Oching. I'm a quality assurance Consolata Hospital Madari, and I'm a result-driven health system strengthening professional with over 7 years of experience in leading and driving growth in healthcare and organizations, and basically trained in strategic management and leadership, disaster management, performance management, among others. I'm also pleased to also introduce my co-moderator, who is Salima Kanji, also quality manager at Aga Khan Hospital. Salima is a quality improvement and patient safety expert, and also certified healthcare management professional, as well as also manages JCI accreditation in her facility, among others, with a wealth of experience. So it is my pleasure to be able to introduce our first speaker, who is Oduor Otieno, who is also a quality improvement advisor with systems evaluation. And Oduor Otieno is a quality improvement advisor at Systems Evaluation Limited. He founded this in 2017. He developed quality management systems to drive improvement in healthcare, working with both state and non-state entities. Oduor contributes to the Health Systems Management Association as a part of the Quality Delivery Technical Working Group, and is Vice Chair of the Health Regulations, Quality and Standards Committee at the Kenya Health Federation. He is dedicated to building resilient health systems that enhance care outcomes. It is my pleasure now to be able to introduce Oduor as our first speaker to be able to present to us. Mr. Oduor.
Thank you, Milan, for the pleasant introduction. And I welcome everyone else who is joining us across the continent and across the globe. Welcome to this forum. So today, me and my co-facilitator, Dr. Kanyiri, I think the Dr. will get to introduce Dr. Kanyiri as we proceed, but our role is simply quite succinct. And what we are going to attempt to do, one, we want to unpack the issues around diagnostic safety in line with this year's the World Patient Safety Day, which is improving diagnosis for patient safety. So what we are going to do, we are going to have an overview around diagnostic areas. we'll talk a little bit about the diagnostic process and try to place the patient at the middle of it, at the center of it. We'll see highlights on how to navigate the communication issues within the diagnostic process, and we'll see some few system-wide solutions that we propose, and we'll get some case studies that we believe and hope will enable us to inspire your contributions and maybe your insights into the discussions that we're going to have at the plenary session, and then we'll summarize it at the end of the day, at the end of the session, where our moderators and us will basically see some take-home messages as we depart. Thank you. Over to you, Milan. Next slide. Yes, you can just flip next. So basically, what we are looking at today, we want to have a look at what really diagnostic errors are, and we will start with trying to get a definition. And our definition, basically, we wanted to look at a more patient-centered definition, and this one is directly from the National Academy of Sciences. And basically, when the Committee on Improving Diagnosis sat down and crafted the definition, we are looking at, one, failure to establish an accurate and timely explanation for the patient's health problems. That is one component, one part of it. And then number two is communicating that explanation to patient. So that is basically a succinct definition that we take home, and with a focus on placing the patient at the center of it all. So when you look at diagnostic errors, in terms of typology, we may have delayed, wrong, or missed diagnosis, with essence that despite sufficient information available within the interaction and between the provider, the diagnostician, and the patient, you may not be in a position to communicate it on time. And then it may be wrong in that the diagnostic was made maybe before a correct one was determined. We'll get into perspective how that comes around. And then it may be missed altogether. And when we look at key contributing factors, we look at a two-pronged approach, whereby it has been established that it can either be originating from the individual, let's say here the diagnostician or the physician or the clinician or the primary healthcare provider, or it might be related to the system. So some of the individual factors that you may be realizing around here may be based on knowledge, maybe the skills of the clinician or the diagnostician, or the clinical reasoning capability in terms of interpreting the information, integrating and interpreting results, test results, or even the clinical information from history and examination of the patient. Or it might just be the various human factors around in terms of the biasness that we may be, any individual diagnostician may be experiencing or having around themselves. And it may also arise from policies within the organization, procedures, or how the care is coordinated or integrated within the system. This also speaks into how the workplace or the work system is engineered or structured in a way that it may be facilitating or it may be enhancing or inhibiting patient engagement or interactions across the organization as they move within the care processes. Next slide, please. And we realize that when you look at the diagnostic process as a standalone process, you may realize that there are various entities that also work within the work system. So these are just some estimates. Globally, harm in terms of patient harm, there are three key harm elements that basically we really that we really keep taking note of. And this year's global report in terms of the patient safety action plan identified that these three key harm areas contribute about 90%. And out of the 90%, we have diagnostic areas. And I think probably this is one of the same reasons why WHO saw it fit that this year we need to look at improving diagnostic safety. And if we look at outpatient services and inpatient services, you realize that 15% of inpatients care problems are as a result of diagnostic problems, and 5% of outpatient care as a result of diagnostic process. And 2 in 3 of diagnostic areas basically are being realized that are system related. Coming to a specific component that we will be speaking about, out of the diagnostic areas that are realized within the healthcare system, 33% of them are due to communication breakdown. And communication failure contributes to about 55% within the outpatient unit. In the emergency departments, we are talking about 23% and 22% of inpatient patient harm out of diagnostic errors as a result of communication breakdown alone. So looking into the African continent, this is just a few examples here. The area of diagnostic errors is not widely studied, and multi-country study data within the African country is quite difficult to come in. But still, we have a few examples that you can look at. For example, in the Mozambican study, you realize that up to 38% of diagnosis, clinically and at pathological level, let's say at autopsy level, 38% were not adding up in terms of misdiagnosis, wrong diagnosis as a result. And something worth noting is that over the last 10 years, this has stayed static. And from the study, you realize that within the maternal deaths seen, major errors were around diagnostic errors that were observed, and this is basically maternal deaths versus diagnostic errors. In Uganda, looking at now hospital admissions, you realize that about 9% of the inpatients were misdiagnosed at admission, and about 70% of these were severe misdiagnoses. And 82% of these were from NCDs of the conditions misdiagnosed the most. And if you look at this also, you realize that not only do we misdiagnose uncommon conditions, but also the common conditions are being misdiagnosed and are experiencing diagnostic problems. So this basically tries to give us a sneak peek into the burden that we grapple with within the hospital admissions, inpatient care, or acute care. If you look at the Kenyan example, this one, we realize that this specific one comes from Bungoma County. And the data here is trying to look at the ratio of unsafe obstetric outcomes that is relatable to diagnostic errors. So out of delayed diagnosis, about 43% of them resulted into unsafe obstetric outcome. And out of the misdiagnosis, we realized that about 38%. And out of the poor or unsafe obstetric outcome, we realized that upwards of 34% were due to wrong diagnosis. And something to note is that often, in most cases, it also has to do with misinterpretation of diagnostic data. That is something quite significant when we look at the clinical reasoning capabilities and interpretation skills of the diagnostician, the clinician, or the physician. Next slide, please. With this in mind, let us try to place the patient at the center of the diagnostic process. We all understand that before the patient gets to the facility, the patient experiences maybe a healthcare problem. And when the patient experiences a healthcare problem, as a practice, what we see nowadays, the patient will try to find out meaning of what is happening before they even step into the healthcare work system. By the time they step into the healthcare work system to engage the health system, one, the primary care diagnostician will have to gather information, and we'll have to maybe order tests, we'll have to interpret the results, and we'll have to make follow-ups in terms of the communication around this. So in most cases, what happens is that we tend not to look at the patient as a significant component of it. And within the work system, in trying to unpack this, we'll be focusing on the diagnostic team members. And a key component of the diagnostic team member here we are looking at today is the patient. And within the diagnostic team members, you realize that the patient, one, has the experience of the symptoms and is an expert of that. Two, the patient will have an opportunity to walk through the all workstations within the work system, something that most of us don't do we don't have that opportunity to experience what happens within the work system. So at the primary entry point, the patient will interact with the diagnostician, the physician, or the clinician. The initial assessment will take place, and with that, the diagnostician will make a working diagnosis, as it always happens, maybe at admission or at the OPD. And the working diagnosis will always be influenced by the information gathered and how this information is integrated and interpreted. From making the diagnosis, the next point is basically the diagnostician making a communication. You remember our definition looked at: one, being able to identify the health problem of the patient; two, making a communication about it. So the next step within the diagnostic process is to make that communication known to the patient. So it may occur that a breakdown within this process may lead to, one, a poor treatment plan developed, and that is where now the patient is exposed to, let's say, the next batch of errors, medication errors or treatment errors, or the other so many errors that we may be having, or maybe, let's say, co-infection or wrong procedures that maybe the patient may experience. So in terms of outcome, we only have two within the diagnostic process. Maybe accurate or timely, or it may be with errors or with a near miss. And as always, this will present us with maybe patient level outcomes and system level outcomes. And all this within the diagnostic process, we are supposed to plow this back into the work system so that we are able to improve the performance of the diagnostic process in terms of delivering better patient outcomes and health system level, better outcomes for health system level. So for this, for our session today, we are highlighting the component of communication, because as realized, communication breakdown leads to about 80 to 90% of that. 90% of the diagnostic errors that are realized within the healthcare system, the work system, and the diagnostic process. And with that, Dr. Kanyiri will basically highlight to us the key elements of the communication pathway, the communication elements that as healthcare workers, as professionals, or as patients, we need to take in to ensure that we are making steps towards improving the diagnostic process. Yes, Milan, can invite Dr. Kanyiri to take us through the next slides.
Thank you, Mr. Duor, for that wonderful presentation. It will take a short time before I introduce Dr. Kanyiri to be able to take a short poll before I introduce Dr. Kanyiri. Please put the poll up. Is the poll visible?
Yes, it is.
Yes, it is.
Okay. So let's take our poll. It is, can take 2-3 minutes to be able to do that quickly. Are we done?
Milan, 2 more minutes and we should be done.
Okay.
Okay, we have a minute. Over to you, Milan.
Thank you. I mentioned previously that we had the pleasure of having two wonderful guests, speakers to us. I wish to be able to take this opportunity to introduce the second speaker, Dr. Victoria Kenyeri, Quality Advisor at Aga Khan University Hospital. Dr. Kenyeri is a certified professional in healthcare quality and also a fellow and a member of International Society for Quality in Healthcare. She is dedicated to pioneering quality improvement in Africa healthcare systems, advocating for sustainable evidence-based solution. Dr. Kenyeri aims to integrate quality and patient safety into practice and medical education to enhance patient outcome. Her interest in research, she's committed to conducting research that advances healthcare quality and patient safety in Africa. With all this humility in welcoming Dr. Kenyeri, I'd wish to take this chance to be able to ask Dr. Kenyeri to be able to present to us. As we welcome Dr. Kenyeri, you can be able to put some emotions in welcoming Dr. Kenyeri to present to us using the reactions that are available on your presentation. Dr. Kenyeri, welcome.
Thank you so much, Milan. And thank you also to Dr. Kanji and my co-presenter, Odwor. We did sit down and decide to put this presentation together so that we are able to unpack whatever we hope that we will get to learn from us. So on my part, I'm talking about communication as the foundation for understanding, trusting, and the improved patient experience. And as Milan said, communication in healthcare does take different dimensions. So we have communication between healthcare workers among themselves, and also we have communication between the provider and the patient. So for today's focus, we are looking at communication between the patient and the healthcare provider. Again, as Odwor has said, the role of communication in healthcare, one is on the diagnostic process, is on information gathering, patient education, that leads them to shared decision making. So again, we'll try to put that into context. There are several decision making processes in the diagnostic process, some that carry a high risk and contribute to diagnostic errors and patient safety events. And we'll start with the patient assessment, which is at the beginning of the diagnostic process, and actually which leads that process entirely. And then we do have the physical assessment that is usually done, leading to a differential diagnosis, an impression and the differential diagnosis, and also forms the basis for determining the correct diagnostic test to offer one and to order, and also the clinical information that will guide the interpretation of those diagnostic tests. We do have the imaging and pathology process, and here communication does come in as well during the explanation of the procedure and also communication of the turnaround time. At the same juncture, we still have the reporting, whereby we do communicate the results to the patients, and this can also come in form of critical values and also provide patient feedback and education in some instances on certain diagnostic procedures that are more risky and even invasive. So really, good patient provider education leads to comprehension of medical information, allows for improved identification of the patient's needs, perceptions, and expectations. And remember, the highest cause of patient dissatisfaction in healthcare service delivery is because they feel their needs are either unmet or their expectations actually were also not met. And we look at now, what is the definition of clear information? One, information that is shared in an understandable, timely, and compassionate way, and whereby we have mutual exchange between the patient and the provider, what we are calling a dialogue of equals. So in this setup, no one is more superior to the other, but we are actually having a conversation in order to be able to create trust between the two. The communication is to be precise, accurate, meaningful, relevant, to be able to be exchanged and understood. But the most important aspects of communication in the healthcare service industry or delivery is empathy. Remember, we owe our patients a duty of care. So these patients come to us to be able to share with us the experiences, for us to be able to interpret that and actually offer care that actually suits their needs. So we have, at the base of it, is the duty of care. Communication can be of...
Dr. Victoria?
Yes.
Just 1 minute. Is the slide the same one that you're talking to? We just have one technical hitch. We're just getting the slides on. It's okay?
Yes, it's okay.
It's okay? Yes. So
yes,
the slides
okay,
are the same to the audience. We are on board. Thank you.
Yes. All right. So in terms of communication, we do have, as we've shown here, verbal communication, non-verbal, written, and electronic. So when I looked at research, it says that healthcare workers tend to give more emphasis to the verbal, which is only 10% of what the patient actually perceives, than the non-verbal, which actually carries 90% of the message. So the non-verbal is the posture, the gesture, the facial expression, and the distance. We also have the tone, the pitch, the pacing, and the volume of the voice. So the verbal is actually crucial because it includes the information about the nature, the cause, the prognosis of disease. But the non-verbal one then significantly affects how the patient perceives what we are saying. And it actually affects the satisfaction, the adherence to the advice that you give, and also the clinical outcome. We also have written communication and electronic communication. We'll go to the next slide. So on the next slide, we'll be looking at impact of poor communication or of communication on healthcare. One, patient safety, which is the basis of this discussion during the World Patient Safety Week. And as Milan has said, it can lead to misdiagnosis, wrong diagnosis, or delayed diagnosis, which are classified under medical errors. So how does this occur? Inadequate information is shared, leading to non-adherence to the test or even follow-up related to the test. So for example, you could even have a missed pregnancy and you're having to put a patient under a CT scan or other risky procedures. High healthcare costs. So how does this occur? So inadequate informed consent. The patient has not gotten the entire information that is required for them to be able to make an informed decision, leading to malpractice suits. Miscommunication of follow-up instructions can lead to poor outcomes and readmissions. And then also, when we look at the aspect of good communication, we see satisfied patients are less likely to file formal complaints or initiate malpractice complaints. We look at the healthcare worker, whereby satisfied patients are also beneficial to all of us as healthcare providers, leading to greater job satisfaction, lower work-related stress, and reduced burnout. Patient satisfaction. So we have the patient feels valued and respected. They have a better recognition and understanding of their problem, and also the diagnostic tests available. This positively does impact on their psychology, mental health, tolerance, power, and the quality of life. And that also is what I also put under patient empowerment. Now let's go ahead and look at barriers on the next slide. So then we look at what the barriers to having effective communication between the provider and the patient. Yes, we are all willing. So one, it could be provider related. As healthcare workers, we don't have the adequate skills. And also our communication skills decline as we progress through our careers. The high pressure environment that we are in makes us, or at times makes us lose focus on the holistic care, suppresses empathy, and also we substitute techniques and procedures in order to get the work done faster. We also look at staff shortages because these are some of the provider-related issues. If we are short-staffed, then we tend to move towards more of clearing the queue and not really focusing on what the patient wants or giving the patient attention. Language barriers are another barrier. So this leads to both reduced satisfaction between the healthcare worker and the patient. And we can all just imagine what it's like to have a conversation between someone you're not clearly understanding each other. And that's the basis of that picture you can see there. Literally, you're in the same environment, but there is a wall between you two. You're not able to understand each other. Organizational culture. So you can have a culture that is resistant to change. And remember, they say culture eats strategy for breakfast. So we could be willing to actually improve patient satisfaction, but then there's resistance to change as the culture in that organization. Time constraints, whereby we have rushed consultations. And actually evidence shows that physicians, most of the time, as the first point of contact, interrupt patients after 18 to 23 seconds. But then it was found that if you just pause and allow the patient to finish, then the patient finishes their thoughts with an additional 6 seconds. There was also another study where they looked at 18 countries representing about 50% of the global population, and they found that most consults take 5 minutes or less. So we all know that really we cannot be able to have adequate information shared between a patient and a provider within less than 5 minutes. And actually in one of the countries, it was 48 seconds. We have cultural or generational differences. So cultural differences come in terms of health beliefs, communication styles, treatment preferences, and you'll find certain cultures would prefer to be communicated to in a certain way. We also look at generations, and you'll find some generations, for example, the older generations prefer more structured conversations, while the younger generations then prefer more of relaxed and unstructured conversations. Limited patient literacy, where patients are not able to understand the medical condition that they suffer from, or they've not been able to go to school, are some of the things, or to be literate, even reading, writing, are some of the issues that can impact patient-provider communication. Use of jargons, and I know us in healthcare, we are so used to that and abbreviations. So when you use tough jargons on patients, on patient material, then they're not able to really understand what you're telling them. And that's why there's always an emphasis. You should not use any medical abbreviations, for example, on discharge summaries, on informed consents. And even when you're explaining these things, then you should be able to explain them in a way that the patient understands. Now, let us look at the communication strategies in the next slide before I hand it over back to Odur. Yes. So one of the communication strategies, or what are some of the communication strategies? Really, some of these are very simple, but they're very hard at the same time. We tend to forget some of these things. So what do we mean by active listening? What do you do when a patient comes to you? Make the patient comfortable, show interest when the patient is talking. Body language, nodding to what they're saying. It just shows there's interest. Active involvement. It just shows that the patient gets to understand that you're actually interested into what they're saying. Do not interrupt them. As you said, most physicians interrupt within 18 to 23 seconds. So this makes them not to be able to entirely express what they wanted to say. Always ask if they would like to add something before concluding. Observe then both the verbal and nonverbal cues for the patient. Because remember, sometimes patients might not be able to express some things verbally, but when you look at their nonverbal cues, then you're also able to get some information from that. And there's one model I found called the relate model. So it basically talks about reassuring the patient with a smile, shaking hands when appropriate, asking for the permission to sit down. For example, you're going to review the patient in the ward, using words like reassure, comfort, and concern, and discussing the reason for the visit. Rather than, I see that you're here for, rather than asking what is the reason for your visit. That sounds more bothersome. Explaining, discuss the care plan, discuss the diagnostic process, narrate your care, what you're going to do and why. Listen and answer questions, listen carefully, and ask, for example, what questions do you have? Or rather than, do you have any questions? So you can clearly tell it's the same wording, but phrased differently. Take action. Provide easy to understand follow-up to the patient. Use plain and simple language. So remember, we said medical jargons are some of the things that actually hinder proper communication. Translation services where required, may be necessary where there's language barrier to be able to support more timely communication and end up to safer care. Cultural competence. So when they say, when you go to Rome, do what the Romans do. So part of being a healthcare worker is being able to learn and analyze what happens in a certain community to be able to interact with them properly. When we teach them, use the teach back technique, not to test their memory, but rather for them to phrase in their own words what you've told them. So if you've given them a brochure, they can refer to the brochure, but they should tell you in their own words what they've understood. Visual aids. We talked about patient literacy. So visual aids is the use of images. So one, they're able to attract and maintain the interest of your audience or your patient, increase their attention and comprehension and adherence to the instructions. So we can all see, even if we might not be able to read, we can see. Lastly, technology is here with us, patient portals. So these are technology advances whereby now we're able to engage patients in the delivery of healthcare with the potential to actually improve the health outcomes and patient satisfaction, whereby now patients have access to their own electronic medical records, access to their own test results and reports, and also it's an avenue to facilitate secure patient and provider communication. Over back to you, Odur.
Thank you, Dr. Kanyiri, for that. And now, mine is just to provide a few well thought out solutions here. Next slide. And we look at how do we have our clinicians stepping up. And here, as much as there are a number of about 7 or 8 elements or areas that we are looking at, but for today, we focus on engaging the patients. As clinicians or diagnosticians, let us use our patients as safety nets, basically providing that right education. And where possible, we provide the FAQs, or where a patient can say, okay, I need to ask this, basically the kind of right questions that a patient should be asking within the diagnostic process. And in terms of patient engagement, we have opportunities. One, engage your patients directly by providing them with the right education, or engage your patients indirectly by use of patient support groups, basically getting that feedback on how they need to go through a diagnostic process or informing them. And the most important aspect here is using patients as an alert system, whereby your patient knows, if this and this happens, I need to inform my doctor. Yeah, if this and this happens, I need to go back to the clinic. And enabling that longitudinal follow-up within the patients and the clinic or the healthcare system, even beyond the consultation room. And the most critical aspect here is one, enabling patients to access data or records that pertains to their diagnostic process at any given time, so that this data is always portable and they can move with it from within the healthcare ecosystem. Next slide, please. And next slide. As we talk to the diagnosticians, we also want to bring this information basically to the patients, because every primary care physician or diagnostician would want a storyteller, a patient who can provide that clear and concise and complete history, maybe in a chronological order. This is what maybe we need to pass out to our patients. That's how they can support the diagnostic process. We need patients who are open-minded, basically, because before the patient steps into the diagnostic process or within the healthcare system, they've already made their own the passive diagnosis. And some cases, they insist on that as basically what they ought to have. got out of the system. And also questioning attitude, what else could this be? Was this necessary? Trying to get that kind of information from the diagnostician, the clinician, or the physician is quite helpful. We also need to inform our patients that how do they escalate or how do they follow through the path of care whenever their symptoms are not in line with what is expected. And that comes up as part of using our patients as the safety net. Next slide. In terms of what the organizations can do, we look at it through the entire system-wide solutions. One, within the work system, the healthcare organization needs to be deliberate and measure diagnostic errors. The healthcare system needs to be deliberate and provide focused clinical decision support tools. And we constantly see this in terms of diagnostic algorithms. These are support tools that are very necessary within the organizations. In terms of diagnostic platforms, improving access and optimizing the available diagnostic platforms is very key. Providing avenues for expert support or second opinion review within the clinician, the physicians, and their peers, that is very necessary. And even for the patients themselves, they need to know that there is always have a right for a second opinion. And then also supporting the patients to navigate the healthcare system within the ecosystem. The next approach, one or level, is around safety culture. We need to empower the diagnostic team, because remember, within the diagnostic team, there are those healthcare professionals who interact with the patients, but they do not make the diagnostic decisions. For example, we have nurses. They interact with patients on a day-to-day basis. They are able to say, okay, this and this is not going well. Can we review the diagnosis? And I think we need to empower our team members and also the patients to be able to talk about this. And mindfulness of the organization in terms of culture. Well, we have mindfulness at individual level for diagnosticians being aware of the various areas that are prone to diagnostic process, diagnostic errors, and also the organization being aware that we can potentially get problems with diagnosis around these errors. And it becomes very difficult when an organization doesn't realize that at the outset. It becomes very difficult to manage that. Case reviews. We have the traditional setup where clinical ward rounds happen. We also need to provide diagnostic, we can call it diagnostic timeouts, whereby a primary care physician can utilize a multidisciplinary setup with the team to discuss what is coming up with the patient, and also to basically get more insights and also help them realize it can be this and it cannot be whatever I'm thinking. We've talked about patient engagement, and in terms of communication here, we really need to try so much possible to close the diagnostic loop. In that, in most cases with our patients, the patient may not be seeing getting response out of the management plan. They simply hope to the next care provider without feedbacking into the healthcare system where they came from. And within the same healthcare system or ecosystem, we need to ensure that we've got integrated care and it's coordinated in a manner that from the one workstation to the next and to the next within the work system, we are able to communicate the plans and communicate the processes that we are undergoing through to ensure that our patients or our diagnosticians are able to follow through with each and every care process. And lastly, in terms of communication, we also need to support our diagnosticians to be in a position or with avenues to speak to the various entities in the diagnostic process. For example, how frequently does a physician call back the radiologist that I was expecting this and what I see from the results is not what I was expecting. What else can this be? That is the essence of interprofessional communication. We also need to strengthen communication within the professionals to enable them cross-reference and also have deeper insights on what might be happening. So with relations to the organization work system, there is one tool that I would leave with us in relation to measuring the diagnostic errors. And within the framework, next slide, within the framework, an organization can look at the entire work system that it has and ensure that within the diagnostic process dimensions, because each and every process area is an area that is ripe for an error to occur, maybe from patient encounter, be it in terms of history and examination. Remember the issues around scale, the issues around clinical reasoning. When we talk about diagnostic testing and interpretation, remember the issues around interpretation skills or information gathering. Remember we talked about referral and consultation, or even an essence of following up and tracking diagnostic information coming through. So within the work system, these are all areas that are prone to errors. And as a measurement tool, your measurement tool needs to factor in all these diagnostic areas, and you need to have a reliable, valid tool that can measure both retrospective data and prospective data. And one aspect of retrospective data, we constantly see this in medicine, the practice of autopsy, whereby the clinical diagnosis and the pathological diagnosis is now given correlation. But we ought now to start looking more at prospective data so that we are able to catch them on time before harm is brought to the patient. And this basically within the framework is to enable the organization to build collective mindfulness that within the system, these are the errors that are prone to diagnostic errors. And this is what builds organizational learning and enables the organization to build better measurement tools as time go by, and basically go through the work system and ensure safety of diagnosis. And within the framework, there are only two key outcomes that you look for. You're looking for improved healthcare value with the wider population, and you're looking for better patient outcomes. And all this information for better patient outcomes, this is the information that you'll feed back into your quality improvement actions to improve the work system of the diagnostic process. And the improved healthcare value, this is what you feed back maybe into the wider system to develop practice, policies, and actions that are plowed back into the diagnostic process to minimize errors as they come. So this is a framework. We can get to use that, and you can distill it more and refine it to within the healthcare space. And with that, Dr. Kanyeri is going to share with us a case study just to stimulate our thinking within the healthcare work system, and see how diagnostic errors basically move back and forth and enable us to realize that it is something that constantly happens within our workstations. And you realize that for every clinician, making an appropriate diagnosis is like the golden rule. Over to you, Dr. Kanyeri.
Thank you. Thank you so much, Odwor. We could start the first case study, and let's interact. I would love to hear your thoughts on this and how this actually is. You can go to case study number 1. The first case study, and I assure most of us, if you've been at the front line, you've actually had such an interaction. So I picked this as a generic case just to preserve patients' information and confidentiality. A child was admitted to the hospital with chronic constipation. He was 5 years old and had cerebral palsy. He was seen by numerous doctors, both senior and junior, and was placed for that hospital. They had a constipation management pathway. So you see, they had all the right tools to be able to guarantee a good outcome. His mother said the constipation was different from that which he usually had. He also had intermittent abdominal pain, but his vitals were normal. The nurses also reported that something was just not right. On the 4th day of admission, the child suddenly deteriorated. On re-examination, it was found that he had volvulus, a malrotation of the small intestine, and this became gangrenous. Despite surgery, he died the next day. So this was a sad outcome, but I would love to hear your thoughts. 30 seconds, you can put it on the chat box. What do you think could have been done differently? Now that we've talked about communication and the role of communication on diagnostic errors, and also what diagnostic error was this. So the moderator can help me click on the chat box.
Yes, Dr. Kanyeri. So we have several chats. I'm just looking for the answer to this case study.
Yes.
Yes, you can see it coming on board. The diagnosis is intestinal obstruction. Yeah. Go ahead, Doc.
So in terms of diagnostic error, so here there was an error. We do appreciate that. What type of error was it? According to what Odur taught us, it can be wrong diagnosis, misdiagnosis, delayed diagnosis. What type of error was that? We can start from that. 10 seconds. Any takers? Yes, we have misdiagnosis, wrong diagnosis, misdiagnosis, missed diagnosis, I agree. Misdiagnosis. Second question, what do you think the clinician would have done differently? What question should they have asked? Misdiagnosis, yes. And Odur, I hope you can tell us the type of diagnosis error is it. It is. Question number 2, what more information should have been sought from the mother? Yes, asking the mother to describe the difference observed in this constipation. And remember, this is what our patients come and tell us. I just don't feel right. Ask the mother why she felt constipation was different, involved radiology, ignored information leading to misdiagnosis, how the constipation was different, fantastic. Ultrasound, investigative capacity was low, needed radiology, good. Explain the difference of the constipation. Odur, what kind of diagnostic error was it? What type was it? Before we move on to the next. Thank you so much, the participants.
Yes, thank you, Dr. Ari. Yes, you realize that the diagnostic error is something that evolves with time. One, at the point that they realize that it's a volvulus, basically they are delayed to make that diagnosis. So it was they delayed to realize that it's a volvulus, being that they didn't basically take the feedback maybe from the mother, and also make use of the various diagnostic platforms available. And by the time despite the intervention they were looking at, you realize that basically they had missed it. They delayed to make it. So one thing that we also need to understand, that diagnostic error also evolve over time. And a diagnosis is not a one event. It evolves over time as the patient walks through the healthcare work system. So that is something also that we need to be alive with. Over to you. Thank you.
Thank you. We can move to the second case study. There is a response he could have done radiological exam. But remember, as we say, the patient assessment is at the key, is at the bottom of it, is the beginning. So had he also listened, then he would have been able to pick, as we said, the right test to be done and also to provide the right clinical information for the diagnosis. So case study number 2, let's get ready to type. A clinician received an after-hours call from a male patient in his 60s. The patient was complaining of weakness and reported that he had started a new blood pressure pill, hydrochlorothiazide, 3 days earlier. He also reported taking lisinopril daily for 1 year. The doctor quickly attributed the patient's weakness to the new medication. He told the patient to stop taking the hydrochlorothiazide and to check his blood pressure using a home blood pressure cuff. The doctor instructed the patient to seek immediate care if his systolic pressure went above 180 millimeters of mercury, but otherwise to make an appointment to see his regular doctor to get a different blood pressure medication. 3 days later, the patient was hospitalized with a sudden onset of right arm and leg weakness, as well as difficulty speaking. He was diagnosed with atrial fibrillation. Based on the patient's symptoms and medical history, the admitting physician determined that the patient's weakness was a result of their arrhythmia rather than the side effects of the hydrochlorothiazide. The findings on neuroimaging suggested an embolic stroke. The patient was treated with warfarin on atrial fibrillation and received rehabilitation while in hospital. So here we do note one instance where there was a diagnostic error and another instance where there was communication to be able to pick the correct diagnosis. So again, to drill it in, what type of diagnostic error was this and what do you think would have happened in this case? Not rather of asking what's wrong with you, what else do you think could have happened as we thought before? I'm looking at the chat. Delayed. Thank you, Frederick. Another response. Another response. We have rushy decisions, yes. Wrong diagnosis, missed diagnosis. Wrong diagnosis. Okay, as the answers continue, remember we said about interrupting patients. So we said generally clinicians interrupt after 18 seconds. You can see from when the patient just said they had weakness, the doctor had already made a conclusion and gave advice based on the conclusion he had already made. Had it taken a few minutes to let the patient explain themselves and how did the weakness start? How has been the progress? What other symptoms have they had? Probably that would have helped them into the direction. And as we can see in this case, the clinician actually had the right clinical knowledge, but the small issue of allowing the patient to actually speak for further to be able to explain themselves then actually led to this incident. Yes, we also have answers. Rapid decisions, patient could have been admitted immediately given high BP rather than delay diagnosis through CT. I did not listen to the patient better and also inadequate exploration by the doctor. So thank you so much. I'll hand it over to the moderators. Thank you.
Thank you once again, Dr. Victoria and Mr. Odwar. It was really insightful, and you can see from the chats coming, the way they are being answered, there is active participation, and the understanding of the session is also demonstrated. You highlighted on key concepts like communication, and interestingly enough, studies show that the same type of statistics run to even relation with adverse events. The less we communicate, the more adverse events we have. Communication is a big factor towards unfavorable outcomes. You also demonstrated how we can use simple tools to enhance our communication strategies, system-wide solutions to make sure that we have better, accurate, and timely diagnosis. Because of time, I will request any further question on the session. The case study questions are noted and the answers are noted. Any other question, and then I will move further. I don't see any on the chat, but there are very good inputs that are coming in. Patient's perspective, follow up, what happens outside the patient's, outside the consultation room. So yes, we have learned, and we have learned to reflect on what we can do better. So thank you for those wise words of wisdom. And finally, I wish to hand over to our acquire team. A big appreciation to the team. They worked with us and burned the midnight oil to come up with such a successful presentation by both of our experts, Odwar and Dr. Victoria, and my co-moderator, Milan. We have worked as a team, and you can see the results. So kudos to the acquire team, and we hand over to you for a few words before we wrap the session. Thank you.
Thank you, Dr. Kanji. My name is Shiro Lande. representing Acquire Frontline Healthcare. We just want to say thank you for all who have attended our webinar. So I think I'll just make this very brief. We will be sharing a recording of this webinar. We will also be posting it on YouTube, and the links will be shared to you on email. We will also provide any other updates. We will give you access to the folder. I will request my colleague, Jacqueline, to please share the PDF document for what was presented today once more. For those who may have missed it, kindly review it, go through it. I want to also add for CPD points, we have the information that you put through while registering. That will be sufficient, and we want to thank Kenyatta National Hospital that will be providing the CPD points. Kindly give this process 2 to 3 weeks for you to receive your CPD points. I will also share a document on email, a Google document, for all our other attendees who are not Kenyans, who would like a certificate of participation. The document, you can write in your details, and then you can say whether you'd like the e-certificate. This is also open to the Kenyan attendees who would like a certificate. We also want to hear about your input, even as we're about to close. Kindly give us your thoughts. This is a cross-learning forum, and we'd like to hear from you. What did you think? How was it? And we just want to say thank you one more time. In the chat box, please note, I will share a link to, if you'd like to join the Patient Safety Working Group, there will be a link where you can put in your information, and thereafter you will be able to join the group, or a member of Acquire will put you in the group. So I'll hand it back to Dr. Salima Kanji and Milan, and they can just say a very quick closing word, to close off. We have gone overboard by 8 minutes, but this is okay. We can have 1 minute at least to say thank you, and we can allow you to unmute, and everybody can say goodbye to one another. Thank you very much.
Thank you once again. And Milan, over to you.
Thank you, Dr. Thank you, Acquire team. Thank you, members, for even listening to us, giving us opportunity to be able to moderate this session. To the speakers, I think we are grateful as moderators that we had a good working relationship. We wish to do this another day. This is great. Thank you.
Okay, then let's have a very good evening on that note, and finally say a very warm goodbye to everyone. Thank you once again.
Thank you. Bye.
Bye. Thank you.
Thank
Bye.
you. Bye.
Thank you and bye.
Thank
you.
you.
Bye.
Bye.
Thank
you very much. Thank you also very much.
Bye.
Thank you. Bye-bye.
Yeah. Thank you.
I love this. Bye.
Thank you. Bye-bye.
Thank you, everyone.
Bye.
Bye.
Thank you. Goodbye.
Thank you. Thank you.